Hello, Ms. Vilasini.
Okay, Dr. Niroja, start.
Hello, everyone. I extend a warm welcome to each and every one of you to be a part of this oral diagnosis and radiology, a clinical insight webinar series. Thank you all for joining us for today's webinar. I would also like to wish all the participants a happy Guru Purnima. My name is Dr. Nirja. I am working at Faculty of Dentistry, AIMS University, Malaysia, and I will be the moderator for today's session, along with my co-host, Dr. Ravi, who is also my colleague, but he will be joining us a little later during the panel discussion. First of all, before we start, my sincere apologies on behalf of the organizing committee for yesterday's webinar because we had a delay in start due to some technical issues, which has been rectified. And now the recording of yesterday's webinar is posted on our AIMS Facebook page and also on Amropin Facebook page for viewing. I also request the audience to bear with us if we encounter any small technical glitches because we have speakers joining us from various time zones. Coming to today's, I would also take this opportunity to express my sincere thanks to the management of AIMS University, Malaysia, and happy to partner with Amropin India for giving us invaluable support and guidance to conduct this webinar series. Coming to today's topic, which is related to the current scenario, that is the pandemic we all are striving hard to survive. It is titled COVID Juggernaut, a first-hand experience from the hospital of UK by Dr. Uzma Sadia. We have Dr. Uzma Sadia here with us, joining in from UK. Welcome, ma'am. It's a pleasure having you here. Dr. Uzma Sadia, she's an accomplished and successful vascular surgeon, currently practicing in the UK. She is working in a hospital in UK. She completed her undergraduation from KIMS, Bangalore, following which she ventured into the daunting territory of DNB in general surgery at St. Martha's Hospital. She has a special interest in vascular surgeries, in which she has done her super specialization. In this field, she is the youngest vascular surgeon and we are proud of her. She is practicing in a hospital in UK and she has also completed her MRCS from the Royal College of Surgeons and continue to grow in strides. She has a very pleasing and charming personality. It's a pleasure to have you with us, ma'am. And coming to the upcoming talk, which is on 11th July, it is on next Saturday. It is a part of our webinar series. It is on. It is titled "Role of Soft Tissue Laser in Dentistry" by Prof. Dr. Manisha Sharma from India. We hope this interests all our participants as well. So before we go ahead with today's, before we get started, the order of today's webinar would be Dr. Uzma's presentation first, which will be followed by a panel discussion. We have three panel experts here with us who will be actively involved in sharing their knowledge and experiences. We have Dr. Isaac Kobi, Dr. Hassan Khalaf, and Professor Dr. Shiv Kumar with us. It's a pleasure having all of you here. We welcome you all. If you have any questions during the presentation, please. Hello. Yes.
Now it is clear. Now it is clear, doctor.
Okay.
Now it is clear.
Thank you. So, if you have any questions during the presentation, can you hear me, ma'am? Am I audible? Ma'am, am I audible? If you have any questions during the presentation, please type them in the Facebook comment box below. We will bring it up during the end of the webinar during the Q&A session, and also fill in the feedback form which will be posted shortly on the comment section. So now without further ado,
I'm worried if this case happens, but no worries. I can be there, no problem. Just 1.5
we will turn time over to today's presenter, Dr. Uzma, to share her knowledge and expertise on the subject matter. Welcome, Dr. Uzma.
Okay, doctor.
A very good morning, and thank you for having me.
Thank you.
Okay, master.
Is my desktop available for everybody to see? Can I have an okay for me to begin, please? Dr. Neeraja, do I have your okay to begin? Are you able to see my screen?
Yes, ma'am, you're clear and we can see your screen. You can start with your presentation. Thank you.
Thank you. A very good morning to everybody, and thank you very much to AIMS University Malaysia and Amropin for having me today. Although the webinar series is on oral diagnosis and medicine, this is a topic which is fairly relevant to every health worker across the globe at this moment of time. And I have a short talk about what it meant for us as doctors in UK and what was our experience during the past few months. When the topic was given to me, I had to look up Juggernaut because having grown up on comic books, Juggernaut often meant the X-Men villain. But when I read up on the definition, it meant a literal and a metaphorical force which is regarded as merciless, destructive, and unstoppable. I could not have found better words to describe this virus, as it has proven itself to be merciless and destructive and so far unstoppable. There has not been a single phase of the human community which is not affected by this virus. And it is a shared experience of every healthcare worker around the world in every field. And we are battling something which is invisible and yet so powerful. For my talk today, I have a fair few things to talk about. I will begin by the boring bits, which is the timelines of the pandemic in UK and the evolution of the guidelines which came about to help us during this time. A few things about the experience which I had working as a doctor in a tertiary hospital in UK. A little chat about the future challenges which we might have coming up and what would be our global objectives going forward. The talk would be about 15 to 20 minutes, and if I extend my time, please feel free to stop me, and I'll try to conclude sooner. I'm happy to take any questions at the end of the talk, and my colleagues who are here on the panel today will help us go through with the discussion when we have the Q&A session at the end. It was in the end of December that the Chinese doctors at the Center for Disease Control first had cases of pneumonia of unknown cause, which later in an article published on the 20th of January was well known to the rest of the world. But it was not until the end of January when we had the first 2 patients in UK who tested positive for the coronavirus after 2 Chinese nationals from the same family were symptomatic in New York. A day later, WHO declared a global health emergency amid thousands of new cases which were now emerging in China. In a very short span of time, after the first few days in February, the number of cases had now gone into thousands all across China. The disease was formally named as COVID-19, which became a household name, an acronym that stands for Coronavirus Disease 2019. This is when the reality hit home. This is when everybody sat up and noticed what's happening. And it was not possible to ignore as something which was happening at one part of the world and something which is not going to affect us wherever it is that we are practicing medicine. In the first week of March, the cases of COVID-19 began to have a huge surge, and on the 4th, it was announced that UK had the biggest one-day surge of 34 cases, bringing to a total of 87. This was a number which we were startled to look at and felt unprepared for at that moment of time. But unfortunately, this was very soon overtaken and the number ran into hundreds. On the 20th of March, the government ordered all leisure activities, pubs, restaurants, gyms, and other social venues across the country to close. There was widespread panic among people who had jobs and livelihoods which required them to travel. And there was some relief given when the Chancellor announced that the government will have to pay 80% of the wages for workers who are at risk of being laid off. This furlough scheme brought some relief to people who were addressing issues of their livelihood, along with dealing with now what was a danger for everyone all across the country. On the 23rd of March, there was a televised address by the Prime Minister which said that the citizens were to go out to buy food only once a week, to exercise only once a day, or to go to work if they absolutely cannot work from home. citizens were advised to comply with these guidelines, and the failure to do so would incur them to have some fines. This is when the country shut down and the rest of the world was to follow suit. In the first week of April, a little down the line, the UK recorded its highest daily death toll of 938 deaths in just under 24 hours. In the hospital where I work, it is a tertiary hospital with an ITU capacity which was doubled almost overnight, and we had patients who were intubated and treated in the ITU section, and these numbers were a reality which we faced every day when we went into work. These numbers continued to daunt us, and it was only later in the month of April that we had some good news when UK government announced that the vaccine trials had started. And at the end of April is when we finally heard the words which we were waiting to hear, that UK had now passed the peak of COVID-19. And this was also when the initiative to provide tests for the NHS workers and for the frontline workers came into implementation, and there were more than 100,000 tests which were doled out in the end of April and early May. Sadly, the trend continued, and even in May, the death toll continued to surpass more than 250,000. There was some relief when we saw the efforts which were taken by the government actually come into reality, and when the contact tracing systems went live, that was both in England as the NHS Test and Trace and the Test and Protect in Scotland. The R value became a household discussion point, and many people who had never heard of it till now were now experts and knew what it meant because it had a direct impact on their day-to-day life. It was because of the very high R value that we had to have the total lockdown in the first few weeks. But as the R value has been decreasing, there has been a little bit of a relief in the lockdown when measures were taken to allow people to go out to exercise as often as they needed to, and also for some workers who are not frontline health workers to come back to work. In the step 2 of adjusting these social measures, there were plans to reopen the schools, but this has been done in a phased manner because there have been small surges of a second wave in places like Leicester. As of yesterday, that is the July 4th, the lockdown has been further reduced, and now a lot of places of leisure have been opened, including places of worship and hospitality services. The timelines don't mean anything because when you have to go to work every day and things are changing every day, you need to know what to do next. All of our lives as doctors and as surgeons especially, we have had a set rule of guidelines or dictums or doctrines which we follow. Wash your hands for 3 minutes, wash all your equipment before you start. These are things we take so much for granted. We don't think about where these guidelines came from. But now we were suddenly left at sea and we didn't have enough to go on. And this is when the trials of time and testing and treatment really came into play. We had to look up at guidelines which were given out to us by the Public Health of England, from the Royal College of Surgeons of England, and also from the intercollegiate societies to help us guide us what to do and how to maneuver ourselves during this crisis. The initial guidance for working during the pandemic came to us on the 20th of March 2020. There were 4 priorities which were listed in this. Number 1 was to maintain emergency surgery capabilities. So this meant that any patient who came with an acute surgical emergency would be dealt according to his clinical requirement without any deficiency or without any hampering in his treatment. This had to be a number 1 priority for the surgeons to maintain, and all of the measures which followed were directed in trying to make sure that this happens. Number 2 on the priority list was to protect and preserve the surgical workforce. The protect was synonymous with the personal protection equipment, the use of which was very quickly learned, and amidst all of the talk of not having enough PPE, I must admit this was not something I faced at any point, and we did have enough PPE available to us, and we did train very early during the pandemic on the techniques of donning and doffing this equipment. The preserving the surgical workforce, on the other hand, meant giving support to our colleagues who were either self-isolating because they were symptomatic, or they were having to take care of someone at home who was unwell from the virus, and generally trying to maintain a tempo at work which doesn't let us think too much and to carry on. The third priority was to fulfill alternate surgical roles. This would mean stepping down for the senior doctors and helping at the middle grade and lower grade. It would mean stepping up for the middle grade and lower grade doctors to fulfill roles which they may not have been completely comfortable with, and also for them to do roles which were outside of their super specialty. The final priority was to fulfill alternate non-surgical role. This was in terms of leadership and in commanding roles where we had to form new teams and we had to form new committees, which helped us navigate through these completely unprecedented times. So what would this mean for every individual surgeon who comes into work? On a current practice at that time, we would be treating patients who come to our subspecialty as an emergency or an elective patient. So we would have to maintain that super specialty emergency surgical treatment. As I work in the vascular and endovascular department, this meant that any patient with a threshold aortic aneurysm, somebody who came with active bleeding, somebody who came with the acutely ischemic leg had to be treated as per norm and as per our past practice. On the edge practice for us meant that we had to maintain specialty emergency surgical capacities, which were outside of our normal comfort zones. For many of us, including me, it was after a decade that we went back to doing general surgical practice. And I did an appendix for a child and an emergency Hartmann's operation after a gap of 8 or 10 years. It was familiar territory, but under a shroud of uncertainty of what would be next and how long this would need to continue. Beyond the edge practice would be training for surgeons in airway and ventilation skills. Some of us were deployed to the ITU, where we were expected to have basic airway and ventilation skills. And although this was not for very long, we had to be present and ready for whatever came to us. For the medical doctors, the current practice in the past would have been to prescribe medications and treatments for the acute and chronic problems the patients come in with, maintaining lines and having a consultant-led daily review and also a triaging. This was slightly modified because now the consultants had to triage patients with a view to send them home as early as possible so they don't end up with infections which they acquire during their stay in the hospital. The medical doctors also did have the on-the-edge practice where they had to treat mild or moderate COVID-19 patients. This was overseen by an ITU consultant, and they were also further trained in maintaining surgical emergency capacities, which was, of course, beyond their normal comfort zone. But everybody strapped up and came to work, not knowing what they would be expected of them, but ready to do whatever was required. This is a rather busy slide, and I apologize for that, but this was a handbook for the surgeons which we used, and this was something which we needed to practice on a day-to-day basis. This was the updated intercollegiate general surgery guidance, which was also used in various super specialties for the COVID-19 pandemic. It came about on the 27th of March 2020, and it has been updated 2 times since then. What it essentially told us was to treat all emergency surgery patients as COVID positive, to test all the patients who come with surgical emergencies with the COVID swab as early as possible. For patients who come with general surgery emergencies and have a CT abdomen done, they would have a CT thorax added during their initial investigation. If a patient was to come in for a planned surgery, we had a risk assessment tool which we filled out for such patients and prioritized them according to that. We had to talk to the patients about the greater risks of surgery because there was, at this time, then evidence started coming in about post-operative mortalities and the various risks which the patients who had an operation during the COVID pandemic would now face, in addition to the post-operative complications and risk which they would otherwise face when they have an elective operation. The consenting process was now a little more complicated. We had to give them the numbers which were available to us about what would be their risk, and whenever possible, we had to reassess our operative strategy. If a patient came in who needed a laparotomy, we would look at having to do a risk reducing step like doing a stoma instead of an anastomosis, one with an aim to complete the operation in a shorter period of time, and second, and more importantly, to reduce procedures which would have a risk of failure because of their current state. The third component of this advice was about PPE. By this time, we were quite clear about what is to be done, and we used PPE for all laparotomies and essentially for all operations from then on. Even patients who had a COVID-19 swab negative, we donned a full PPE before operating because we knew by now that there was a 30% false negative test with this swab. We almost always use eye protection, and we practice donning and doffing. In the theaters, a minimum staffing level policy was applied. All the staff which was involved in the operation was to have a full PPE, including visors. We stopped using positive pressure ventilation, and devices like diathermy, which had smoke extraction, was now made as compulsory. The intubation and extubation of the patients was done in the operation theater and not in the anesthesia room, with a 5-minute break before the procedure was started. Whenever possible, we would take measures to prevent aerosol generating procedures. If it was an amputation, we would use handheld bone instruments and avoid an oscillating saw and thereon. Laparoscopy was generally avoided. This was because there was initially a view that the filters would be difficult to implement. Whenever possible, the most common general surgery emergency like appendicitis was reevaluated for an open or a conservative management. The same was true with cholecystitis, which could be treated with a conservative measure or a stopgap measure like cholecystostomy. Endoscopies were done only for emergencies, and they had a separate guideline from the BSG, and all upper GI endoscopies were now considered to be an aerosol generating procedure and required full PPE. The NHS and the GMC has a good practice guideline which we follow every single day during our practice in UK. But the COVID-19 good practice for surgeons and surgical teams was given out on the 1st of April, which had 4 components. We are quite relieved to receive this because this gave us further clarity on our daily practice. The first component was adapting ourselves and our surgical services to cope with the COVID-19 crisis. This meant that we had to triage our non-emergency work. We had further advice about how to prioritize our patients, which I'll speak about in my next slide. The delivery of surgery in UK is done as a hub and spoke model. So our hospital would be a hub where there is referrals which come in from various spoke hospitals, and our hospital would receive such referrals and treat them as required. There were lots of changes which happened in the rota. These changes were almost as frequent as fortnightly. Like I mentioned earlier, most of the doctors were reassigned to a COVID rota, which would mean they would be put in places where they were needed, irrespective of their specialty. This is also the time when we started carrying out more and more virtual outpatient clinics. The telephonic clinics were arranged, and this meant that the patient could have a conversation with their doctor even if they could not have a face-to-face meeting with him. Secondly, we started speaking about what to take into account when working outside of one's comfort zone in an extended scope of practice. This included advice for trainees who were now stranded in places where they had been training for over 8 months and there was no scope for them to move to a different training post until this problem was resolved. There was also advice for surgeons who were returning to practice from self-isolation. The caring for patients at the end of the life was something which we had to relook, and the practice of putting a DNAR or a DNA CPR for our frail and elderly patient became a priority. and we had to have very difficult conversations very often with our patients due to the risk of the virus, in addition to their multiple comorbidities. There was again reinforcement about protecting the workforce, including advice for infection prevention and surgeons and the team's well being. The one set of unsung heroes in this pandemic were the infection prevention team, whom we called at the drop of a hat for every sort of advice. And they were very generous with their advice. And this helped us immensely when we were left not knowing, even with all of the guidance we had had so far. On the 23rd of June 2020, we had a clinical guide to surgical prioritization during the coronavirus pandemic. This essentially divided the patient into 5 priority levels. So the level 1A would be patients who needed an emergency operation, like an active bleeding, which would be immediate within an hour, or somebody who came with an acute appendicitis or a diabetic foot with severe sepsis. A priority 1B would be an operation which needed to be done within 72 hours. For example, a patient who came with a above threshold and symptomatic aortic aneurysm, or somebody with an acute limb ischemia. A level 2 would be patients who could be deferred for operation up to 4 weeks. This would commonly be patients with stroke or TIA who needed a carotid operation. And of course, the patients were level 3 and 4, which could be delayed up to 3 months or more than 3 months. This included a cohort of patients who needed reconstructive operations and also oncosurgery when the cancers could be treated more than 3 months later. We are happy to be in the recovery stage of our surgical services, and we have had a few key tenets for returning to our regular work after the COVID pandemic. Some of them were, as discussed earlier, key considerations include, before resuming the elective services, would be to look at the workforce and think of all the people who were self-isolating. At one point, there were more than 1,000 people, employees of my hospital, who were self-isolating on a single day. This meant that we had to resume our elective services with a reduced workforce on every front. We had to develop cohesive leadership and have frequent communication. A lot of doctors took up the role of arranging and providing meetings and links for MDTs and M&M discussions, which have now become a part of our daily work. And this kind of leadership and using tools like Zoom and Microsoft Teams has now become essential to our practice of medicine on a day-to-day basis. We had to assess the surgical workload because by now we had a huge backload of patients who needed operations to be done, and we needed to assess a patient population because we had new sets of patients who are now being labeled as purple or green, who have been earlier treated or earlier self-isolated or already tested positive and now have been tested negative. So this required a lot of juggling between how we see the patients as elective or non-elective, and if elective, how we would have to manage them depending on their past history. We had to ensure that there was enough hospital capacity because some of the wards were now converted into a COVID ward. Some of the ITUs were now exclusively for COVID patients, and various facilities were reduced because they were redirected to where they were needed more. We had to enhance the workforce capacity. This meant we called upon people who had recently retired and doctors from non-clinical specialties as well to come in and help as needed. There was reconfiguring of the services. This was in places wherein the hubs needed to bring in workforce from the spoke hospitals, especially the nursing services, which had to be reconfigured and also have new rotas so they could fill in any gaps which came up. This surgical workforce had to be supported. They needed a place where they could vent, where they could speak up, where they could discuss their current issues, whether they were related to work or in general with what was happening. A lot of emphasis is given now to patient communication because the consenting, like I mentioned, is much more complicated. Supporting training is now being offered for every grade of a hospital worker so that they know how to handle any infective waste and in general how to maintain the social distancing within the workplace. As of last week, we have 2 more tools in our kitty. That would be a virtual consultation tool, which gives us guidance on how to deal with patient questions and how to assess patients when we have a telephonic or a virtual consultation with them. And also a consenting tool, which helps us go through the consenting process and having discussions with patients in relation to their operations and the delays and their possible future outcomes. So that was an overview of what were the policies and how they came about. And as I mentioned, I work in a place which deals with a tertiary level of care. And this was an experience which has changed me as a doctor, and it has made me stop and rethink about my practice and made me realize that some things which we had forgotten during our practice as doctors need to be revisited time and again so we keep understanding what is important. In the initial days, we quite frankly didn't know what we were doing. And we would walk into the hospital and we knew that we had to wear a mask, whether it's a surgical mask, it's an FFP mask, who's to say? But we were patting each other's back, feeling like heroes, being told we are heroes on television and everywhere else. And it got to us, and we were foolishly optimistic, thinking that this is going to pass in a week or so. And all we would try to tell ourselves was not to panic. But we did panic very, very soon. It was on the weekend when the COVID pandemic became a real threat when I was on call. And I was on call with a very senior consultant of mine. And I remember walking into the emergency room wearing my surgical mask because that was the advice at that point of time. And I went into the adult resuscitation where I had an elderly man who came in with a ruptured abdominal aortic aneurysm, extremely unwell and fighting for his life. As always, we started resuscitating him and doing various things which we needed to do before we could take him to the theater. That's enough to keep anybody's adrenaline level very, very high. To add to this, I noticed that everybody around me was now donning a FFP3 mask, whereas I wasn't. And it also struck me that the patient who is lying in front of me has come from the community, possibly positive for COVID, is very high risk in terms of his age and comorbidities. And I did panic because I looked around me and I looked at the patient, and for once, it was not clear whether this was enough in terms of protecting myself. This stress started to mount on all of us, whether we wanted to talk about it or not, whether we wanted to accept it or not. And there were lots of unknowns at this point of time when we didn't know how easily we could acquire the infection and how it could be passing to us among ourselves and between patients. And this was a real threat to anybody who was working in the hospital. And these things became quite complex because while you're at work, you're thinking about work, but when you come back home, it all comes back to you and it hits you at one point of time. And that's when the stress builds up. We were made aware that we are the frontline workers and it is our duty and our privilege to defend and protect the rest of the population against this crisis. But this did not mean that we should not acknowledge our own fears and think of the exposure and think of things which could go wrong. We all come back to a family which we worry about and we have to take care. After the first or second week, when I would come home, it was a ritual of scrubbing with very hot showers in an effort to wash away the virus. Myself included, most doctors did a sort of self-quarantine at home when we would not be keeping close contact with the rest of the family, and we would try to sleep in separate rooms and whatever measures we could do to feel that we are protecting our family and not be a source of threat to them. This was a battle which each one of us fought on an individual level, and we fought it together. And I'm proud to say that we did make it through. A few weeks later, when we started to understand what's going on and how to deal with it, we came back to our optimistic view of work. Sometime in May, when I was getting ready for work in the morning, I turned on the news and the front of my hospital is on BBC News with a headline which says, Royal Stoke Hospital Emergency Department has now said that they are not capable of dealing with the emergency workload which is coming to them. This is where I'm going to work in 10 minutes. So that did not help in getting there any faster. But we had to get to work, and it was work for which we were grateful because we still had the option of going and meeting our friends, meeting our co-workers, and having a sense of normalcy, which the rest of the world was now struggling to hold on to. This was mixed with a sense of detachment from the rest of the society, who were now talking and complaining and comparing notes about what self-isolation has done to them. I would scroll down Instagram with some jealousy almost, with all the copious amounts of banana breads and dalgona coffee which people were making and having, and cribbing about having to stay at home while we went out and had to deal with what would essentially be quote unquote work. So, coming back to work, now PPE was king. It was the new trend, it was the jizz, it was what is in thing to do. And we were very clearly told what is to be done and not to be done. And for all aerosol generating procedures, as shown here, we would have a full PPE, which is something we continue till date, with a full face shield or eye protection, IFFP3 mask, gloves, and a fluid repellent gown. Every time that you walk up to a patient and talk to them, you need to have a surgical mask and gloves and a disposable apron. This seems fairly easy and efficient thing to do, and it is. But there is another aspect to this which we realize once we have to do it over and over again, that when you approach a patient donned like this to have a friendly chat, maybe on the morning when he's having his operation, it does not come out to be very friendly. And you try your best by giving them confidence, but it is very difficult when you cannot shake their hand, pat them on the back, and tell them that it's okay. Social distancing between a patient and a doctor is a very difficult thing to do. There was once a patient at the end of my first COVID rota who was a 79-year-old lady who came with a pseudoaneurysm which had ruptured in her thigh, and she was very unwell. She had signed a DNA CPR as soon as she came in, and we knew that she was not going to make it. And every time I walked up to her to inquire on her, it was very difficult to make eye contact or to give her a smile of confidence with behind a mask. This old lady had 12 children, and we had to arrange for a conference call with all of them on an iPad, because at this point there was no visiting allowed. And some of the children who spoke to her over the screen also had masks on. And I imagine this would not be the time of farewell she would want it from her family, but that's a reality, and that's something which will stay with them for the rest of their lives. What's next? Of course, testing. Tests which are more available, tests which are more accurate, tests which are more accessible to everybody who are not just healthcare or frontline workers. That would be the need of the hour. This would include an antibody test and a swab, which may have to be repeated for most of the health workers. And anybody who's had a swab for COVID would tell you, me included, that it's one of the most uncomfortable things you can go through. But if that needs to be done every 2 weeks, sign me up. Treatment. I'm not going to go in detail of this because I'm not, to be honest, very up to date with what are the newer drugs which are now have been approved by proper trials, and I would leave it to the experts to comment and discuss this. Of course, vaccine is something which is going to come in and hopefully make the situation better, and is definitely the light which is at the end of the tunnel which we are all running towards. What this pandemic has taught us is, no matter where you are, what language you speak, and how you deal with this crisis, there is an underlying sense of collaboration, because what we went through as a medical community is an experience which is unique to us and that is shared by all of us across the globe. And this sense of unity has to be extended when we talk about doing trials, about doing research, and sharing our knowledge in all of these topics. What has been highlighted during this time is the importance of guidelines and protocols in modern medicine, and how we feel lost when we don't have this to guide us. And these need to be reevaluated and revisited by many of us who are not involved in writing the guidelines, but who have to make a practice of going back and reading up and trying to stay updated on what is advised. We have to revisit the basics of medicine. By this, I mean that since we are specializing as specialists and super specialists, we sometimes tend to forget the basics. This was a time when many of these super specialists had to read up on basic things like intubation, the difference between acute lung injury and acute respiratory disorder, how to prone a patient, and things which we took for granted when we were medical students or in the initial years of our practice. And as we became consultants and moved on with our careers, we almost tend to forget what were the basic medical practices. And this was a wake up call to see that we hadn't actually forgotten, but it was something which was worth revising and revisiting, even at any stage of career which we are at. Change of practice. The patients who used to walk into the emergency rooms before the pandemic were all sorts of aches and pains, which were weeks and months old. And suddenly, all of these patients stopped coming in when the pandemic happened. So we had to ask ourselves this question: did these patients ever need to come in the first place? Was this something which we could have handled at a community or a GP level? Change of practice in the way we have consultations with patients, be it a virtual consultation, a telephonic conversation, and how this can be almost as effective in, say, a post-operative chat with the patient than having to make them come all the way to the hospital for a 5 to 10 minute discussion. These are things which we could carry forward in our practice, and I think they are here to stay. This also includes using various non-face-to-face communication tools to have meetings such as this one. The backbone for all treatment and all recommendation and for all future treatments has to be based on research. There are dozens and dozens of research projects which are going on all across the world. My unit has been involved in a few of these research projects, which are international projects. We are trying to collect data to come up with treatment modules, to come up with prediction tools for risk assessment of patients, and various other things which have to be based on solid research instead of speculation, so that the recommendations which come out of such research can be held strong and into practice for years to come. So what did I take away from this experience was, no matter how bleak the situation looks, it's inherently a human trait not to resign to fatalism, and that's something we need to remind ourselves every single day, and have a principle of preparedness where we have to change ourselves, adapt ourselves, and take up roles for which we are not ready, for putting ourselves in situations which are uncomfortable and challenging, and take up roles of leadership and commanding when and how required. Equally important would be to have a principle of being a good follower when it is required, and be recruited as a soldier for which we have been training all our lives. As always, the patient should be our first priority, but this does not mean that we have to neglect what all of our practice and our work does to us. It's okay not to be okay. It's a good plan always to extend a year to a colleague who seems out of it, or to give yourself a leeway to think about what this has done to you, and to carry on with a smile as we have done so far. I thank you for the patience, for listening to a topic which, like I said, is out of your specialty, but that was the point of the talk, to say that there isn't a specialty which is spared, and we have to come up with an attitude at the beginning of a task which has been so difficult and which has changed all of us. And hopefully this would make us a successful global medical community. Thank you.
Thank you very much, Dr. Uzma, for sharing all your experiences and challenges you've been facing currently in the operatories in your hospital setup, and where everyone everywhere are at risk. And we are really proud of our frontliners risking themselves and their families during these testing times to make a difference. Now, I would like to invite my co-host for the day, Dr. Ravi, to moderate the panel discussion session.
Thank you, Dr. Nirija. A warm welcome to all the panelists. A good day and warm greetings to the audience who have been patiently sitting and listening to this informative webinar. As of now, I would request all the panelists to switch on the videos and unmute themselves for the discussion. Today, we have 3 panel experts. I would like to first welcome Dr. Isaac Kobe. Dr. Kobe is a trained vascular surgeon, currently working as a registrar at the Vascular Surgery, University Hospitals of North Midlands, UK. Currently, he is a part of the team connecting Tier 2 and Tier 3 observational studies at Royal Stroke University Hospital under the Vascular and Endovascular Research Network. Besides, he is also a part of the team connecting the PAN-SEARCH study at Royal Stroke University Hospital. He has presented numerous papers at various international and national conferences and has a lot of publications to his credit. The second panelist of the day, welcome, Dr. Kobe. Yeah. And the second panelist for the day is Dr. Shivakumar. Professor Dr. Shivakumar is currently a professor in Oral Medicine Department in Babu Banarsi Das College of Dental Sciences, Lucknow, India. He has over 12 years of postgraduate teaching experience with several national and international papers to his credit. His area of interest is orofacial pain and is experienced in special care dentistry. Lastly, he is actively involved in upgrading the undergraduate curriculum and has worked on the concept of comprehensive clinics in Uttar Pradesh, India, to upgrade the dental practice. We welcome you all.
Thank you.
Yeah. So before we start with the question and answer session, thank you, Dr. Uzma. We will go ahead and take some questions now. Just a reminder to the audience, please be sure to type your comments in the Facebook comment section. Yeah, it looks like we have a few questions. One of the audience, sorry, asks about. This question has been directed towards Dr. Uzma. He asks, could you suggest the best way to guide people, especially aged people, about the safety rules one has to keep in mind to protect themselves from COVID-19?
Thank you for the question. Yes, I think my specialty especially deals with people who are of the elderly age group with a mean age of 71 years. And most often, we advise them to follow what has been told by the general guidelines. Initially, it was for them to completely self-isolate, not to go out for any essential activities, and even things like groceries were brought to them. In the phased manner, this has been now a little bit turned down, and they have been allowed to go out, I think, just to meet close family. The best advice I would give them is even now to stay indoors unless required, because the vulnerability of these patients is extremely high, and that means that they should try and stay away from any social activity as much as possible. And if needed, they should be going out to exercise close to their home, and preferably maintaining social distancing. And I would also give them suggestions to have somebody very close to them who are available for any kind of an emergency, because the worst thing for an elderly patient to happen to have is when they're unwell and they can't access emergency health care. So I would suggest that they have somebody maybe checking in on them as early as possible. And lastly, they should contact their GP or their local doctors as soon as they are starting to feel unwell, because we have noticed that this virus doesn't behave the same with everyone, and people have come with as mild as a thing as a headache and been tested positive and gotten progressively worse. And if they are feeling unwell, please go out, please make a call and seek help.
Thank you, Dr. Uzma. That was quite informative. Thank you so very much. And then we have a question for Dr. Kobe. Being an advanced country, the UK, United Kingdom being an advanced country, why is the incidence so high? I mean, not only in UK, but even in Europe, where they are expected to have superior medical facilities. The incidence rate is also very high. Could you kindly please share your insights on this, please, Dr. Kobe?
Thank you so much for the question. So just to correct you a bit on the introduction, I'm actually a general surgeon.
Oh, okay. Thank you.
I'm a general surgeon currently practicing or working as a registrar to become a vascular surgeon. I'm also an aspiring tennis player. As you can see, there's a tennis racket behind me.
Thank you.
After many years. So just to answer your question, yeah, so this has been one of the ironies of COVID-19 as to why are these countries which have advanced healthcare systems seemingly succumbing to the pressure of COVID-19. And I think we are here. I wouldn't say I'm here as an expert of COVID-19. I'm here as someone who has experienced COVID-19 or have an experience of COVID-19 in this country, I would say. And there's a lot that we don't know about this virus. I think there are a lot of things that have been suggested. So one of them is that the mean advanced age of patients or generally population in this country could have something to do with it. Because one of the positives of an advanced healthcare system is that people live longer. The average life expectancy in the United Kingdom is somewhere in the mid-80s and increasing. And we see a lot of people who are elderly patients who are actually living very active lives. And I think also this becomes a disadvantage in terms of increasing their susceptibility to COVID-19. So this is one thing that might explain it. The second thing is just the lifestyle of the population in terms of their social makeup, their social background, the way people interact. That some of the ways in which people interact then increase the spread of the virus. And I think the last thing would be the fact that, and this is something that is debatable in terms of the reaction of the countries to the virus. When the virus first hit China, I think everyone presumed that China is really far away, despite the fact that we know that it's just a few hours by plane. And when the first few cases started sort of cropping up in say in the UK, still the impression is that that this virus would be easily conquered. I think lastly, and more importantly, is that I think everyone really underestimated this virus, that this virus really is a smart virus in terms of the fact that it utilizes the ways in which humans interact to spread, the fact that it's been quite unpredictable. And as Uzma intimated in her talk, that there's no perfect test, we're moving from one test to another. So I think the underestimation of the effect and the capacity of this virus probably is one of the biggest things that led to it really causing havoc in advanced countries. But I would say lastly that there is another unknown factor X, which maybe we might decode later. I think we still don't know so much about this virus. As late as 2 days ago, I read an article in the BBC about, we're wondering how come Japan has aged population. People in Japan are actually quite old. Birth rate is low, aged population, but the mortality rates are quite low. You know why? If that is something you're saying. So there's a factor X, which we probably don't know, that may be lying in the genetics. But as I said, the things I've intimated are probably some of the predispositions why we think we had a lot of problems in sort of richer countries, I would say. Yeah.
Okay. Thank you, Dr. Kobe. Speaking about the situation in Japan, there's a person from the audience who says, since the UK government already knows the demographic structure of the population in UK, and since it was well known, that there's a numerous or a huge percentage of aged people. Why do you think the NHS was slow to react to the COVID-19 situation, especially in the month of March? While especially when Italy and other countries were feeling were reeling under immense pressure.
So tough question. I'd say it may be a situation of so there's the underdog and mentality, and then there's the opposite. I think because the UK has actually been a world leader in terms of teaching other countries about epidemics, about handling emergencies and handling pandemics. My own view really is, I think there was an underestimation of the effect of this virus. The reason I say this is that once everyone got on top of the game, once we had the guidelines that Dr. Uzma has presented, once we had all these social distance measures, we after some time saw effects. We saw the incidence of the virus go down. We saw the mortality rates go down. So, but by the time this was put into effect, the virus had already set foot in the country, and there was a lot of community spread. So really, I really feel that there might have been an underestimation of the presence of the virus in the country and what it would do to the population. Really, that's what I think.
Okay. Thank you.
Everyone else might have their different view.
Thank you. Thank you, Dr. Kobi. There's one more question. One of the audience asks, what is your advice with regard to happy hypoxia or silent hypoxia and to both the doctors and the patients? Dr. Uzma can shed some light on this, please.
Well, any treatment which has happy in it should be a first line of treatment, according to me. I have heard of it, but I'm no expert, like I mentioned, about the treatments which are coming around. And I would not advise it because I would not advise it based on the current evidence which is available. There have not been enough trials and enough evidence which is backed up by research to say that this is something which could help everybody who is reeling under the effect of the virus. Nevertheless, I think it's a branch of medicine which is worth exploring, and if oxygen makes you happy, so be it.
Oh, thank you, Dr. Uzma. And this question is for Prof. Shivakumar. Me being a dentist and my friends being a dentist, we always try to look at the oral manifestations of COVID-19, if it really shows any signs, symptoms, So, Dr. Shivakumar, sir, can shed some light on this, please.
Yeah, when this disease started, nobody knew what was oral manifestations because they were all treating with the lung disease and other aspects. Later, when patients started complaining about loss of taste, they thought there will be some involvement of some other reason for loss of taste. But when most of the COVID patients started complaining of loss of taste and xerostomia, people started relating with that. I read a recent article which is published in National Journal of Medicine, which stated that the first symptom, rather than congestion of the lungs or difficulty in breathing, is loss of taste. In that article, which mentions that the initial symptoms, the cough, cold, and difficulty in breathing comes later. The first symptoms will be the loss of taste for a COVID patient, and followed with xerostomia. And because any virus which enters starts from the mouth or through the nose, the symptoms starts showing from the lungs before everybody used to think like that. But later, nowadays, people are correlating that it could be starting from loss of taste rather than difficulty in breathing.
Thank you, Dr. Shivakumar. And being in UK, how strong do you think is NHS push? Are they really pushing the limits to serve the population in UK, or how stressed are they at this, during this difficult times? Dr. Uzma, can you really describe how how exhausted you people are, how strong you are doing this at this moment.
It's interesting that we're having this conversation today. It's the 72nd NHS birthday on 5th of July
Lovely,
today. So, from a personal experience, I think what NHS is to people in UK is something which is poorly understood by people who are outside of UK. So we have to understand that even though this is a country which is advanced in various various places, medical care comes with a lot of its own difficulties in terms of managing the workforce. And most often we would have problems with workforce in terms of having a hospital, say, who is staffed with X number of people. But what we had the difficulty was this X became X minus a certain number because people within the hospital were starting to get infected and taking time off. So that was a huge impact on the workforce itself. And we had to do a lot of reshuffling, and people stepped up and they worked out of their comfort zones. And it was not always easy. It was something which everybody stepped up to the challenge, I think. And one thing which I found very encouraging during these few weeks was as doctors, especially as surgeons, we try to tuck away ourselves in operating theaters and try to stay away from management as much as we possibly can. And this was broken. This divide was broken. We were forced to have conversations where we were included in making policy changes, and there was a sense of camaraderie which happened between all specialities, which I think was very encouraging, because of all the jokes and comments apart, the gynecologists and surgeons and ophthalmologists were working shoulder to shoulder, and I would never have imagined it to see it in my practice, but I did. And I think we should give credit where credit is due to NHS, because
Yes.
it worked with very limited um, uh, uh, facilities, and they were burdened heavily, and everybody stepped up to the game. And I think we did the best we could.
Okay, thank you, Dr. Uzma. There's one question that has been directed by one of the audience to Shivkumar sir. How do you take precautions from unknown visitors, as they can be carriers of COVID-19?
Yeah, the protocol for the dental practice in India has been changed. There are so many rules and regulations have been put forward from the government and from the public health sector. So even the practice of dentistry, or even the practice of medicine, or even the surgery has been changed. As Dr. Uzma told, she never thought that she will face this kind of situation in her life. Working with multiple doctors, like we see patients, and like the question was for any new patient or a new unknown person who comes, how to know whether that person has to be treated positively or with a high risk or a low risk or a thing. Like when we knew the manifestations are of a different category, because we don't know what is exactly the strain of this virus. Still, many things has to be research has to be done. For some patients, it has shown it has reacted in a different way. Many articles we read and many news we see, and many things we come across in WhatsApp or some other group. This patient was an asymptomatic. This guy was very asymptomatic until he found he was having difficulty in breathing, and he expired. Like, how
Oh.
to know what kind of patients we come across. With my experience, I have come across many positive patients who are asymptomatic. And recently, my neighbor tested positive for coronavirus, and she was very healthy. She was normal. She was walking. She was doing all the work until unless she was. I don't know how it came, through the maid or through the other person. Now, how to deal with this? How to know what kind of symptoms, like whether it could be difficulty in breathing, or even ulcer in the mouth, or even xerostomia, or whatever. How to know this kind of patients, whether it is asymptomatic patient or a symptomatic patient? It's very difficult.
Okay, thank you. There's one particular question that has, that has, been directed to Dr. Uzma and Dr. Kubi. It's got a lot of technical things, and I've read it out for you. How accurate is the pulse oximeter in terms of diagnosing COVID-19 patients in the UK? Is it widely being used as a screening tool in the UK, considering that even for RT-PCR, a 15% false negative test has been reported by the CDC? So this is a question from my colleague, and obviously he's used too much of those terms, and so please, we'll be very grateful if you can elaborate and explain on this, please.
Okay, then I'll go first.
Yes, thank you, Dr. Kuli. Yeah,
I have probably read about this once. I do not think that it's used for screening or diagnosis of COVID-19. So there are certain symptoms that are indicative symptoms of COVID-19, because we know that it mostly affects the pulmonary system, the chest, and of course the body. So things like fever and cough. And then other, I would say, how do I put it? Indicators that you might have been exposed to someone who has COVID-19, like someone who has active symptoms in your household and things like that. So those would be screening features, I would say. We do. Problem is we do not have, as I said, I talked about COVID-19 virus being the smart virus, the perfect mimicker, because as of now we do not have a test that is 100% sensitive or unspecific. Maybe there's one currently now which we're not aware of, and we do not have, and all the tests do have a certain rate of false positives and false negatives. Both the PCR swab test and the antibody test, which is not even really being used as a test for diagnosis. So the answer to your question really is I'm not aware of any institutions, facilities using pulse oximeter specifically as a diagnosing test. Maybe a screening feature for patients who come into hospital to decide whether they need to be put on certain treatments like oxygen or some other supportive treatments for the lung, but not as diagnosis. I don't know if any of the other panelists have a different view. Yeah,
okay. Thank you, Dr. Kubi. I think there's one more question. Thank you for your patience. Dr. Krishna Priya Gajendran, she asks, which one do you think is better? Either following one type of precautionary steps worldwide or country-wise customized precautionary steps towards COVID cases, especially from dental aspect?
Yeah,
please, Dr. Yeah, please. This question is directed to you because they want the dental aspect. So please.
It is like for a precaution, or can you repeat the question?
Yes, please. Yeah. He or she asks, which is better choice? Either following one type of precautionary steps worldwide or country-wise customized precautionary steps towards COVID-19. Yeah, thank you. Yeah.
I got it. It's very difficult. I think we all can agree to the fact that it's very difficult to follow the same type of precaution in every country. Compared to the different state of mind of the healthcare workers, like the amount of effort what Dr. Uzma is doing comparatively less in some other countries. I don't think so. Precautions what they take and what provisions, what facilities from the government, from the hospital, and from the patients, like how good the patients are here. In some of the countries, the reaction is entirely different. The support, starting from financial, starting from PP kit, starting from many other aspects, reimbursement for the doctors. I don't think so. The precautions what other countries follow will be the same, should follow by other countries. Even for example of in India, here many of the doctors are not paid. I heard they are not paid salaries for months together. What I heard is in UK they are paying double salary. I don't know.
That's not
what
true.
I came to know.
At least for us.
Yeah, I agree.
What I came to know, like people are telling in other countries they are paid more compared to the rest of the countries. So what precautions, like how to safeguard us or the family members or the patients, it's depending upon different aspects of each country. It doesn't mean that we should not each country. In our own country, in some hospitals, like if you go to the Fortis hospital, if you go to the Medanta private hospital, the precautions are different compared to the government hospital. In our government setup, it is entirely different. So many things are not followed till now. No social distancing, no precautions. There is no hand sanitizers are given. There is few of hospitals still giving gloves and mouth masks distributed. I have seen a few colleagues of mine. They take their own mouth mask to the hospitals.
Yes, yes.
They are not getting. They take own hand sanitizers to the hospital. Compared to other countries, it's left to each and everything. They should follow one protocol, of course. That one protocol is protect yourself and protect others. That is a very important goal for each and every hospital or each and every country. First is to protect everyone. Like that is the main.
Okay. Thank you, sir. One final question before we end the session, and the testing protocols, Dr. Kuri, how far-reaching are they, and how comprehensive are they to to make sure that it helps in patient it helps patient with COVID.
So I think testing,
Protocol.
yes, I would say testing is an evolving art. It's an evolving science. I think we agree on that. Testing is important because testing identifies, one, who is at risk of getting the disease, two, who has the disease, or three, maybe who has had the disease in the past. So this might be some of the goals of testing. I would say that testing has improved. I'm not sure whether it is possible to say that testing is optimal. I would say testing has improved. And when things started then, we would identify a case of COVID as a patient who has symptoms. And so there was certain case definition put out by WHO or Ministry of Health, some of which I have mentioned in my previous discussion. This case definition was improved by having a positive PCR. PCR is an antigen test, isn't it? Presence of an antigen in the body, which is a swab test. Initially, we had concerns with how the test was done. I think we've improved on that. Okay, so we have reduced the percentage of false positive tests. That is, patients who have positive results who actually do not have the disease. Okay, although more of our concerns were on the false negative, which is patients who have active symptoms, or maybe you don't have symptoms, but actually have the disease, but the test has not been accurate enough to detect the disease. And this is why I think Uzma mentioned that in the storm of the pandemic, we assume that all patients coming in for surgery as positive, whether or not they had a positive test. From then on, we came this new test called the antibody test. And this antibody test, up to now, it's not really clear what we are doing with it, to be honest. So like in our hospital, all staff are being tested for antibodies. Okay. So some people came as antibody positive and others came as antibody negative. But it's not, there's really no difference, because after that, everyone should do the same things, should protect themselves, PPE and things like that. So we are not sure. I think we can safely assume this test is more for research purposes rather than anything else. Okay. So in summary, what I would say is that yes, it's an evolving art and science. It is helping in treatment. So, for instance, a patient who comes in as at now, a patient who comes in with symptoms and has a positive PCR test is sort of presumed to be positive and treated as such. A patient who comes in with symptoms, very suspicious symptoms, and tests negative, I would say is mostly treated as a positive patient. Okay,
Correct.
unless they've had a second swab. So there's a regime of testing in that a patient should have an initial test, and then after a certain period of time, then they should get a second test. And some institutions will take a second negative test to mean that you are negative. Okay, some institution will take a third test. Or if you've been initially positive and then you have 2 negative tests, then you're taken as negative. Okay, so this is important in terms of one, where the patient is treatment. In the hospital setup, hospitals are now have zoning regions in terms of green, blue, and purple, depending on your COVID positivity. Okay, and even in terms of wards, in terms of theaters, in terms of a lot of these treatments that you get in hospital, because we are trying not to mix the patients who are positive and those who are negative. So the testing is important in trying to reduce the spread of the virus, such that patients who are positive or who are suspected to be positive are treated in one zone, okay? And the staff who are working in that zone are getting extra sort of equipment and protection and things like that in terms of resources to protect them and to protect other people from getting infected from these patients.
Yeah.
So in this way, I would say testing is important in terms of limiting the spread of the virus, but it is something that we're still working on.
Okay.
Yes.
That was very informative, Dr. Kubi. Yes, Dr. Shukma.
Yeah, now I have a question for everyone like that. I was thinking, now the patient is treated for COVID-19, this disease. He is tested positive. Then he went for a home quarantine or a hospital quarantine for 15 days. Then in 15 days, he went into isolation. Now 1 month, he's been treated and he's become negative. Now that person starts freaking out. He is enjoying, he's moving around, he's telling everyone, I was positive one month before, I'm negative now. Now I can do whatever I want. And is it like he can be once again contacted, like he can become positive after a second test like that? If he becomes positive for the second time, what precaution like we should take?
Yeah, I think either Dr. Uzma or Dr. Kubi can answer that.
Yeah.
That's a extremely valid observation, Dr. Shivkumar. And I think this is something which we are dealing with right
Yeah.
now. When most people, even healthcare workers who have tested positive for the antibody test, are assuming that they are negative, and they are being lax about their social distancing, and they're not taking enough precaution. But to our knowledge, I don't think we, as of now, know whether it is possible to have a second infection even after being positive. And there was once believed a few weeks to months ago, that the immunity lasts only for 6 months, but this has been recently challenged, and we honestly at this point don't know whether you can be treated positive again, we can be tested positive again. But I think we can't keep taking it forward and isolating somebody forever uh, because they've tested positive once. Based on the evidence available now, if they are tested positive, self-isolated, tested negative, then they should maintain social distancing just like everyone else.
Everyone.
And I think it was, if I could elaborate on what you said earlier about your patients who come with problems with oral health. When we are trained uh, initially, even with HIV or retrovirus, we were always said that test them and, double gloves and all of that. And as the years went by, we do that for everyone. And that became the new normal. And I think even with this coronavirus, the new normal would be always to have some sort of, we'd be more than aware to use eye protection, to use proper face mask, because what is important is not just what the patient has come in, it's also important what you and I could be giving it to them.
Lovely. Yeah, that was very informative. Thank you, Dr. Uzma. And it looks like we have covered all our questions. Finally, Dr. Uzma Sadia, is there anything else you wish to say before a wrap up of the session?
It's been a really good discussion, and I'm happy to be a part of it. And
Thank you.
I'm glad this initiative is involving people from various specialties the way it should do. And thanks to the organizers. And I think everybody who are participating would agree that we are fighting something which is evolving faster than we can catch up, and we need to put our act together and try to beat it to the curb. Thank you.
Okay. Thank you, Dr. Uzma. Great. Thank you. Thank you, Dr. Kobi. Thank you, Dr. Shivkumar, for being here. We really appreciate you being here, and on all the audience who have been patiently listening for the past few hours. And thanks again for joining us today, and we will see you next time. Thank you.
Thank you very
Thank you
much.
so much. Thank you. It was a very nice. It's a pleasure. Thank you. Thank you, sir. Thank you, ma'am. Thank you.
Thank you.